Hi, this is Mrs. Shepherd, and we're going to talk about airways today. So a couple things when you have a patient who maybe is having some difficulty with their airway, you always want to make sure that your suction is on and working. So you're going to turn it all the way to on. We generally only use intermittent for G-tube and NG-tube stuff. Okay, it's on. When I'm suctioning, I can either use a suction catheter that could be 8 to 14 French, or I can use a yank hour. This is a firm, curved, it has a large suction bore in the middle and then some around the sides. We generally will use this for a mouth. So this is the yank hour. I'm going to just wash my hands. The next airway we're going to talk about is trumpet, a nasal trumpet, nasopharyngeal airway, which I kind of love. It's one of my favorite airways in the whole world. A nasal trumpet is used for somebody who has maybe sometimes a big tongue, a patient with Down syndrome, someone who needs some help with their airway. This is a nasal trumpet. You can see that it's flared at the end. It's very flexible. It's silicone or rubber. We size it by going from the patient's nair to their ear, and actually that's a really good size for him. So once this is ordered, we're going to explain to the patient. I'm going to put a nasal trumpet just to help with your airway. Okay. This should not make the patient gag. This should be just lay quietly on the back of the pharyngeal part. So we just gently put some water-soluble lubricant on there, flip it in. So now there's a nice airway, a nice opening directly to their pharyngeal airway. I'll be right back. Directly in through the nose and just lays on the back of the pharynx back here, so it provides a direct airway. Sometimes with a large tongue, it'll flop back here and cause some hypoxia. So with this trumpet, it makes a nice path. The other nice thing about the trumpet is that you can throw a nasal cannula on this person to supplement their oxygen. Not only that, but if you needed to suction this patient, this is a very clear path right down here. You can get a very good suction. Sometimes you'll hear a patient who has a bad cough, a rattly cough after a CVA. You can hear it just kind of rumbling around back there, and they don't have the muscle tone to get that mucus up. When you suction them nasopharyngeal with a trumpet, you can grab that right up and pull it out. Very, very helpful. So I'm going to take that out. The next airway is an OPA. This is an oropharyngeal airway. You see these used in ORs for patients who are not all the way conscious. These will stimulate a gag reflex, so your patient should not be completely awake, alert, and oriented. You are again going to size it from the ear to the corner of the mouth. And when you put this in, what you're going to do is you're going to curl it in sideways and then flip it up. And the tongue should be lying right here. So when I put this in, I'm going to follow the teeth and then just flip it up. Now, inside here, so again, when I put it in, I'm going to follow the curve of the teeth and then flip it up so that this is following the curve of the tongue, and it holds the tongue forward, and it provides a nice pathway. You see that? How lovely that is? That is quite lovely. But again, it will stimulate the gag reflex, so you do need an altered level of consciousness to use this piece of equipment. The other nice thing about this is that this is completely hollow, so if you needed to suction your patient, you could also use this OPA to suction your patient and get a good, nice, deep suction. Okay? The next airway that we'll talk about is the endotracheal tube. This is a number 7. There's different sizes for different type people. I'm probably a 7. We usually go by the size of somebody's pinky. A small person would have a smaller size, would have a 5 or a 6. A large person, say somebody who's 6'5", would probably use an 8 or a 9. There's a line down the center of it that's radiopaque so that we can check placement. There is a couple open areas. There's some measurements along here that you need to be aware of because we're going to record this when we intubate the patient, where the tube is at the lip line. There's a balloon that can be inflated at the end, that will be inflated, that holds this in place. It's very important that this balloon stays inflated. You can check the pressure by checking this balloon here. It should be firm, but you should be able to move it. It shouldn't be taut. If it is taut, then that means this balloon down here is also too taut and will be causing pressure on the inside of the patient's trachea, and will then cause a pressure ulcer inside there, and that may lead to many, many, many different things. But when this goes in, the balloon is deflated. The doctor will probably even use a stylet, and all that does is give the tube some rigidity. So when this goes in, it goes in directly through the mouth. Sometimes nasal intubation is needed if there's a bunch of trauma, but it's usually kind of easier to go in through the mouth. The doctor or respiratory therapist or anesthesiologist will visualize the vocal cords and go down through the vocal cords here. Okay? So it will end up, not that far down, it will end up about right there. We'll then inflate the tube, and we will check for placement. Now we check for placement in a couple different ways. First of all, the easiest way to look to check for placement is to look at the patient. Or do they have equal chest rise? Or is it just on one side? Lots of times it'll get intubated into one side. The other thing is we're going to look at the end-tidal CO2. Remember, we used end-tidal CO2 when we did nasogastric tube intubation. And all that is it's checking for CO2 at the end of an expiration. Now, if this is in my lung, will there be CO2 with expiration? You better say yes. So that would be a way to check placement. And we will definitely always get a chest x-ray to confirm placement. We wanted that chest x-ray to be, it's probably going to be portable, and it'll be very soon after placement of the chest, or of the endotracheal tube. Okay. It should be a few centimeters above the carina. The carina is where the trachea splits into the bronchus. If it's at that junction, then it's going to stimulate a constant cough, which is not good for the patient. A cough once in a while is good. A constant cough is bad. And then the last airway You pause it. So the last airway is a trach. And a trach is going to be on a stoma on the outside of the body, and it's going to go directly into the lungs. On an adult type person, they're going to have a cuffed trach, and a cuffed trach, again, is simply going to hold this tracheostomy in place. It's going to hold it right there. We're going to assess the balloon at least once a shift. For a neonate or a pediatric type person, the trach is not cuffed because we don't want any damage or pressure to that precious little delicate trachea. So that's going to be an uncuffed trach, but you have to make sure that it is securely in place every time because that little baby is going to be wanting to put their hands up and, you know, they just grab stuff and pull it. So that would be the last airway. Now, a person can live with a tracheostomy on room air for however long. Maybe they've got some difficulty. Maybe they've got a tumor up here that they're not able to oxygenate. If they do need supplemental oxygen, we would generally put them on a trach collar. And that trach collar should be humidified because they don't have the benefit of the nares and the sinuses to warm and humidify the air. And if we're supplementing 6 or 8 liters of oxygen, we're going to be drying all this out and putting them at risk for infection because their mucous membranes aren't able to do what they should be doing. So those are a couple things that you want to think about. If they're on a trach collar, then they need a bubble bottle. If they have an endotracheal tube, they probably don't need a bubble bottle because the ventilator itself will be humidified. There'll be a filter, an inline filter that will provide humidification for that patient. And those get changed every 24 to 48 hours depending on hospital protocol. When we suction tracheostomies and endotracheal tubes, we can do it with 2 methods, open or closed. Open method is more for a tracheostomy, or if we do it with an endotracheal tube, it's just an emergency type thing, something that's acute. We would use a closed system as much as possible because a closed system provides sterility, where an open system, there is much risk for contamination.